Hello, everybody. Welcome to this new IHCH Junior Clubs. We are again happy to have a lot of people joining this IHCH initiative. Here we have the pleasure to have two great speakers. We have Dr. Ebrar Uzun, that is a medical student at Istanbul Medical University, Turkey. And we have Professor Meral Beksac, that is working at the İstinye University, Ankara Live Hospital. So we will have very soon the presentation by Ebrar that is going to discuss relapsed refractory multiple myeloma with the involvement of the central nervous system that were successfully treated by Elranatamab, the bispecific monoclonal antibody that target BCMA. And just don't forget that you can send your question through the chat, and we'll try to address them after the presentations with Ebrar and Meral. So please, Ebrar, the floor is yours.
Dear all, first I want to thank the organizers for giving me the opportunity to share our case, who was diagnosed with multiple myeloma and developed CNS involvement, which was successfully treated with Elranatamab. This particular male patient was 37 years old at the presentation, and he was suffering from an acute and gradually increasing back pain localized to lower back area and a shortness of breath, which was apparent last month. He visited his family physician, and a complete blood count indicated a severe anemia with a hemoglobin level of 8.5. The initial lab tests revealed a normocytic normochromic anemia with a hemoglobin level of 8.5. Creatinine level and calcium levels were all normal, and LDH was 125. He had a severely increased total protein with a decrease in albumin, and beta-2 microglobulin level was 11.9. Then we have planned to further investigate the case for an accompanying monoclonal protein and a possible myeloma. Bone marrow aspiration and biopsy revealed a lambda-restricted plasma cell clone comprising 80% of all bone marrow nucleated cells. Paraprotein studies revealed an IgG lambda M protein with level of 6.93 and the serum free lambda light chain of 2320 milligrams per liter, and the serum free light chain ratio was less than 0.01. Patient was diagnosed with an IgG lambda ISS stage 3 and revised ISS stage 2 myeloma. Fish studies were all normal, and PET scan showed multiple vertebral lesions with soft tissue components. Most prominent one was at L3 vertebra, the pedicular region, with an FDG SUV max of 9.7. The lytic lesion, which aroused a large portion of T10 vertebra with a soft tissue component, and lytic lesion in pelvic bones, ischium, iliac bones, and bilateral femur. He was induced with VCD because of renal failure at the time of presentation, then switched to VRD as soon as the creatinine level was normalized. Auto-transplanted with MEL 200, maintained with bortezomib plus lenalidomide because of disease severity at the time of presentation. At the 6 months of autologous transplantation on bortezomib plus lenalidomide, maintenance, he relapsed with an increasing serum M protein and new plasmacytomas, and a worsening renal function again. He was planned to be salvaged with KCD, who responded well with severe and hard to manage cytopenias. A second transplant was planned to overcome cytopenias and to further continue the treatment. He did well with KCD and second autologous transplantation for a short while until progressing with a huge plasmacytoma on right-hand rib and others in the lumbar vertebra. He was planned to be salvaged with daratumumab-containing regimen, but needed a much more rapid response and salvaged with KRD pace instead. After KRD pace, he obtained a good remission and switched to DVD. DKD and DPD were not reimbursed to keep the response and planned to switch DPD as soon as the reimbursement issues are solved. But unfortunately, just after the second cycles of DVD, he developed a diplopia and CSF sampling showed leptomeningeal involvement of myeloma with no mass in parenchyma. At that time, a compassionate use program was initiated with Elranatamab, and patient was planned to receive Elranatamab for the treatment of both plasmacytomas out of CNS and CNS involvements. He did respond well and did perfectly well with a complete response, even regarding the plasmacytomas out of CNS, and even CNS involvement with a grade 2 CRS and no ICANN. CSF plasma cell count was 0 for 3 consecutive sampling throughout the treatment period. He was followed up with CR for 10 months until progressing with neurological symptoms like diplopia and re-emergence of plasma cells at CSF. He was salvaged with addition of pomalidomide and tremelimumab dafralimumab of elranatamab according to a positive KRAS mutation in the NGS panel obtained from a plasmacytoma, but he was lost to sepsis after a short while. I will continue with a brief presentation on CNS involvement in myeloma. Multiple myeloma is a cancer characterized by the monoclonal proliferation of plasma cells in the bone marrow with extensive infiltration. Multiple myeloma with involvement of central nervous system is a rare and devastating extramedullary complication of multiple myeloma. It is observed in about 1% of myeloma patients, and it may present with either leptomeningeal infiltration characterized by the presence of monoclonal plasma cells in the cerebrospinal fluids or with intraparenchymal lesions. CNS myeloma is associated with a poor prognosis 3 to 6 months post-CNS myeloma, despite the use of various treatments, including proteasome inhibitors, immunomodulators, intrathecal chemotherapy, radiation, combined therapies, and high-dose therapy, followed by autologous stem cell transplantation. Even treatment with novel agents did not confer a survival advantage, and unfortunately, these patients are consistently excluded from clinical trials of modern treatments. Blade and friends have published this review in 2022, which was a systematic review of literature in extramedullary disease. They have well-defined and separated extramedullary disease from paraskeletal plasmacytomas. In this systematic review, CNS involvement was discussed separately. Treatment approaches were diversely various with a stable, poor outcome. Both patients who presented with CNS involvement and who relapsed with CNS involvement afterwards included. Greek colleagues have published their own set of CNS myeloma data in this year. They have shown that an extramedullary involvement was the only independent predictor of CNS myeloma. They also compared the outcome of CNS myeloma patients with controls and were able to show that both PFS and OS were poorer in CNS myeloma group. The treatment approaches were all diverse, including both chemo-based and novel agent-based approaches with no T-cell engager therapies. Multivariable analysis revealed that extramedullary involvement, leptomeningeal involvement, and treatment before 2016 were independent predictors of poor outcomes. A real-world experience with teclistamab by Dima and friends have included 4 patients with CNS myeloma with no further conclusions about the outcome. Monotherapy with anti-BCMA bispecifics showed that patients with extramedullary disease are still doing worse. Even with CAR T-cell therapy, the difference between outcomes of patients with EMD and no EMD is not blunted. Bispecifics are appealing options to treat extramedullary disease, and a much appealing option seems to combine to other bispecifics. The prognosis of EMD still remains poor despite of the advent of many highly efficacious modern therapies like bispecifics and CAR T-cell therapy. But there are some preliminary encouraging data from the combination of teclistamab and talquetamab, and we will be eagerly waiting for the final results of redirect trials among the subjects with CNS myeloma. CNS myeloma patients should be regarded as a challenging population and be the subjects of specific investigator-initiated trials, even excluded from early and late development trials of modern therapeutic approaches. Translational studies are needed to identify the possible mechanism of CNS involvement in myeloma and to further identify the best therapeutic approach which should access to the tumor cells via crossing blood-brain barrier. Bispecifics are becoming a standard of care approach in the treatment of relapsed myeloma, and we believe our case will be one of many encourage the use of this kind of modern therapeutics in the most challenging scenarios like CNS involvement. Even we do not have a clear idea about the concentration in CSF and brain tissue or the probability of crossing blood-brain barrier in both intact and injured sites. Thank you for listening.
So thank you very much for this very interesting case and very successful treatment for this overview of treatment of extramedullary disease, and in particular of patients with CNS involvement. So again, for the participants, do not hesitate to send your questions through the chat. So first, Meral, what do you think about this case? In the same situation with these patients, with this history, at that time with relapsed with CNS, you would have tried the same thing, a bispecific antibody, or would you discuss some other option at that time?
Well, this patient is from the beginning a high-risk patient. I mean, presentation with a high tumor burden with renal impairment. And when I look at the response prior to stem cell transplant, it is only PR. And after the first stem cell transplant is VGPR. And within the first 6 months, even with PI and IMiD-based maintenance therapy, the patient has progressed, and with some paraosseous involvement as well. And so it looks like the patient has no cytogenetic abnormality from the beginning, but I would would like to pursue the cytogenetics and also the NGS at progression at the subsequent relapses to be able to see if there is any targetable one that we can use for a novel treatment modality. And one of the important issues is, I mean, so far there is no real concrete data on the use of a bispecific in central nervous system involvement. And so the approach from the Medipol team was very courageous, and it was very effective for not a very sustainable, but for a sufficiently about 6 months of duration, which is a good one. So far, the patient has not received radiotherapy, which could have been done when the maximum response was achieved after the central nervous system involvement with a good response. I think the physicians and maybe the patient was very happy to have a very good response, and they didn't want to have a radiotherapy exposure. And then the progression happened both in the blood and also in the central nervous system. So we don't know which is the primary event, if it's the resistance in the central nervous system or it's in the marrow, which is causing the progression, because we know that there is a trafficking of malignant cells from the central nervous system to the blood and vice versa. So these are the issues. So if I can summarize, so from the beginning, this patient is a very high-risk patient. It is from the functional high-risk perspective, it fits the definition of functional high risk, and the outcome with outside of marrow involvement is the fate of such patients, and so I assume there could be some 17p deletion in this case because of the behavior, because of the resistance to the chemotherapy and to high-dose alkylating agents. And again, radiotherapy could have been involved, and maybe Ebrar has already this question being a potential question, and she might have an answer for it. But by the way, I would like to congratulate her. She's a medical student, and this is a very difficult case. I mean, forget about a medical student. I mean, it's even a difficult case to present for a fellow in hematology training. And so I would like to congratulate her for this very elegant presentation and very clear presentation.
Thank you so much. And I want to answer your question. The patient didn't want to have radiotherapy because of potential complications.
Yeah, but
So
we pay for it. Yeah, sorry, Lauren.
yeah, so yeah, you want to do it, but the patient don't want to do it. Yes, I understand. Just did you discuss at one point to do some intrathecal chemotherapy? Because we know that before all this treatment, it was what we used to do, to use intrathecal. And did you think that maybe we should combine both? So we said, no, we'll try just be specific and we see what happened.
We have used intrathecal therapy for twice. While the patient on Elranatamab.
So he received some chemo, some intrathecal chemo also.
Can you say it again? Sorry.
He received some intrathecal chemotherapy.
Methotrexate.
Okay, so maybe I miss it. Okay, so yeah, to help to have the myeloma clearance at the beginning.
When did this treatment was given? During Elrana or before Elrana?
During Elrana, not before or after. During Elranatamab.
So in that case, the benefits of the treatment, we cannot claim it only on Elrana, but also the combination of intrathecal therapy as well.
Yeah, it's a combination. And regarding the toxicity, did you see did you see some side effect?
Side effects, actually, I can say that grade 2 CRC, nothing else.
No, no, I can't. No, this is very important point because we know that in CAR T cells, when the central nervous system involvement may drive and increase the risk of ICANS. So we may expected and maybe worried about the risk of ICANS in these patients. And for some people say, no, we should not try this. We'll have some very severe ICANS. We're going to kill the patient. So you give us a very important data because you show this is feasible. Nevertheless, there is also the use of methotrexate. Maybe also the methotrexate may I prevent the ICANS because you give them together. But what matters at the end is that it works for the patients. So
But of course, there's another issue. The Elranatamab was given for how many months? For a long duration, but the interthecal therapy should have been given for a short period. So there was a time where Elrana was given without any interthecal administration to prevent the side effects.
Intrathecal just for 2 times.
Yeah. So I agree, Meral, but the thing is that after we have a clearance of the myeloma and maybe the risk of ICANS decrease over time. So maybe this is important, good also to have this kind of prevention at the baseline, and the methotrexate may have helped to prevent the ICANS. So of course, we speculate this is only a single case, but still, what we are here also is to learn from that and to know how we can use this in our daily practice if we have a similar case. So you give us some very good insights. So really, again, thank you, Ebrar, for bringing this case for these junior clubs. I don't know if there is some question from the people that attend. No question so far. So the patient relapsed, unfortunately. And what happened after the relapse?
I can say that he received pomalidomide and Tremelimumab. I remember that. Daprophenib. Yes, pomalidomide, Tremelimumab, and Daprophenib, as I remember, for KRAS mutation.
Yeah, and we know that the patients were very severe disease, very aggressive disease, probably the 17p deletion, as said by Meral, high risk. So yeah, we expect that at the end it will fail, and that unfortunately the patient probably will die for the myeloma with the relapse of the CNS. So we know this is what happened. Of course, what would have been interesting is to try talquetamab, but it is not available or very difficult to have access to. It would have been another option, but very difficult to have access. The other thing is that may have been discussed is, should we use CAR T cells if they're available in this kind of patients? I don't know, Meral, if you are aware about some evidence of CAR T in patients with CNS involvement.
I think there is very rare data. It's very few cases published, so it's very hard to say that that's the golden standard to go, because the duration of response, the sustainability of response in this setting is very poor, even with CAR T. I think there is some Japanese or some East Asian data which is presented on such few cases. But you know, in bispecific field, to use the same target BCMA bispecific followed by BCMA CAR T, maybe that's not the ideal solution. Another way could be to use a antibody drug conjugate if it's available. And because in the resistance that develops after bispecific therapy, there are multiple mechanisms, including antigen loss at the allele level, because we know that BCMA is expressed on 17p. And it could be, although it's a rare situation, that's one of the reasons. And I would be very interested to see the BCMA expression on the marrow plasma cells in this patient after the progression. We have some few cases where we have seen that BCMA still is expressed in the extramedullary site. The marrow is clean, but the progression is in the extramedullary site after the BCMA bispecific. And so the problem is in the extramedullary site. The immune competency in that site is not enough for the bispecific to perform its maximum efficacy. And the next ASH meeting, there are going to be very, very, very important data being presented on the gene expression of parallel samples from the marrow versus the extramedullary site. And there was a similar presentation from the New York group in the last IMS meeting, which shows that the extramedullary site genetic structure is not always the same as the marrow genetic structure, which makes the disease more difficult to treat. And in this setting, it's difficult to make an assumption whether to continue with the BCMA or to change the target, or even to change the structure of the drug, a bispecific CAR-T versus an antibody drug conjugate, or maybe dual targeting, such as the redirect study, but that's still a bispecific. You still depend on the T cells there.
Yes, so thank you, Meral, for bringing that, because this is now the question of the mechanism of resistance that seems to be very complex and not the same with the bispecific, depending on the target. And of course, there is the role of the microenvironment for the extramedullary and of the T cell that have to be able to access. So even if the extramedullary myeloma still express BCMA, it doesn't work. So there is something else, or maybe there is some kind of sort of exhaustions of the T cell that are the key effectors. So we still have a lot to learn from this new treatment of this new immunotherapy, how to sequence them, to combine them. So this is very, very exciting, this new field. I'm totally in line with you regarding that. And this is from case like that we are also learning. On that we have some new evidence. Of course, it would be great to assess the BCMA both into the central nervous system and in the bone marrow in this patient, but it's not always easy to do. So we have not have a question, but we have Ezra. Hi, Ezra, that say congratulations to you, Ebrar, and that thanks you, Meral, for mentoring all the med students, all the residents in Turkey in the field of myeloma. So yes, you are really doing great with us tonight. So I think we are coming to the so I have somebody that raised a hand. So Aifa, you want to ask a question? Yeah, we can hear you.
Very good, thank you. Thanks, Ebrar, for your presentation. It was very beneficial for our inputs. I have a question. How many days later did you observe the CRS for your case?
Just 3 days.
3 days after the Elranatamab treatment. Right? Okay. How many days later did the subject fully recovered result from grade 2? How many days the subject fully recovered result?
Just 2 days.
Just 2 days. Okay, thank you.
Thank you.
I have different experience in Elranatamab studies in clinical trials. I would like to ask you, is the similar cases? Thanks, Ebrar.
Thank you.
Thanks for this meeting.
So yes, with Elranatamab, what we see is that we are very frequent cytokine release syndromes. Most of patients, this is grade 1, but we have a few grade 2. But we know that this is easy to manage, and people over 2 to 3 days will recover and will be fine. So, and it seems to be the same here in these situations, the rare situations. So, I think if there are no other question, yes, we are now at the end. I don't know, Ezra, Meral, if you have a last comment, something you would like to share, an additional thought on the case.
Well, thank you. This has been a great opportunity to bring forward a young student to present and have the experience to go on stage in front of an international audience. And this is a great opportunity. And thank you for your guidance and for this initiative. I think it's important to approach the young people because they are the future. Thank you.
Yes, there's the next generations of hematologists around the world. So, do you want to say something, Ebrar?
I want to thank you all for your kind invitation.
So, thank you again. Thank you. Really huge congratulations to you, Ebrar. You do really great as a med student. We were very happy to have you with us tonight. So I remember you that it will be available through the IHH platform if you want to watch it again, to share with friends, to bring some more knowledge. Just keep posted regarding the next webinar that will be live. There is some of them almost every week, and I will be happy to see all of you very soon again. So have a good evening or end of the day, depending on where you are, and bye bye.
Goodbye.
Have a good night. Thank you.
Bye bye.